Welcome to another session of Dentistry and More. We'll be continuing with the question paper discussion in oral radiology. So today's topics that will be discussed are the ideal and the faulty radiographs, X-ray film and accessories, processing, then the intraoral radiographic technique and the extraoral radiographic techniques. Under the chapter of ideal radiographs, which you can refer from Freni Karjotkar itself, they have a huge chapter about it itself, the ideal radiograph as a chapter as such. Once a question has been asked relevant to ideal radiograph, you should start off with the definition. It is one that provides a great deal of information. The image exhibits proper density and contrast, have sharp outlines, and are of the same shape and size as the object being radiographed. And then you should talk about the attributes to have an ideal radiograph. Those are the density, contrast, resolution, sharpness, and the speed of the film. So all these categories you have to speak about what are their definitions, that is density, contrast, resolution, sharpness and speed, followed by what are the factors that can lead to an ideal radiograph, which has been explained well in the chapter An Ideal Radiograph by Freni Karjotkar. So next chapter is about the faulty radiographs. Under faulty radiographs, the first question that can be asked is what is an X-ray film processing? Describe the composition and function of the processing solutions and then discuss the causes of faulty radiographs. The first part of the question that I'll be explaining in the further slides. Here I've just mentioned what are the processing solutions, that is you have a developing solution and the fixer solution, and in that you have to speak about the composition of each of the solution. That is, in the developing solution you have the developer, you have the activator, preservative and then the restrainers, whereas in the fixer solution you have the clearing agent, the acidifier, preservative and the hardener. So what are the composition or the ingredient for each of this and the function that should be described well? It has already been given in the textbook of oral radiology by White and Farrow, where they have explained under the chapter of film imaging. Under that they have spoken about the components and functions of each of the solution, so you can describe in detail. So here I've just mentioned what are the contents in the developing solution. You have a developer, activator, preservative and the restrainers, and each of the ingredients in the developer, that is phenidone and hydroquinone. Then you have in activator you have the sodium hydroxide and the potassium hydroxide. Then the preservative is the sodium sulfite and the restrainer is the bromine containing compounds. So each of the ingredients functions that should be highlighted in this answer. Same going on with the fixing solution itself. Even in the fixing solution you start off with what are the components, that is you have the clearing agent, acidifier, hardeners and the preservatives, and the ingredients related to that, that is clearing agent you have the ammonium thiosulfate, then you have an acidifier, you have the acetic acid, preservative is the ammonium sulfide and hardener is the aluminium sulfate. So what are their functions that should be described in detail to answer this question. So the further question that has been asked are the discuss the causes of the faulty radiographs. So here are the list of the causes for the faulty radiographs. Again, there's a chapter called faulty radiograph in the textbook of oral radiology by Freni Karjotkar, where she has mentioned about what are the causes for the faulty radiographs, starting off with the 4 causes, that is projection errors, exposure and processing errors, then you have the miscellaneous technique errors and the automatic processing errors. So under the projection errors they have enlisted all the errors with their cause as well as how to correct them. So have a read about each of these error, that is apical ends of the tooth is being cut off, then you have the occlusal plane that isn't being tipped or tilted, all of the specific areas are not seen, herringbone effect or the tire track appearance. This can be asked as a short note too, that is herringbone effect is nothing other fish bones that is seen by the name of the fish is the herring fish, where the bone is found to be almost looking like a tire track appearance. What is the cause of it is because the film is placed opposite side, it is not placed on the right appropriately, that is normally your film is, you can see that you have a white surface as well as the envelope surface of that, you will see there is a blue and a white color. So the white surface that you see is where you are facing it towards the X-ray exposure. So once What happens in this is that you have in the composition of film, you have a black film, and also within the film you have a black film, as well as a lead foil film is also being placed. In that, the lead foil is placed near the back side of the enveloped cause an X-ray film. So what happens in that, you have, if you open, once you try to expose a film, when you try to process it, you might notice in the lead foil itself there are these kind of tire track appearance that you see with one end. So what happens is that once you try to place the film in not in a position, it is placed opposite way around. This tire track appearance is seen first, because once the X-ray is exposed, it is found to be enclosing, or it is found to be attracted towards the lead foil, and then it passes to the X-ray film. So that is why at first itself you can see this lead foil film wherein they have this kind of a tire track appearance has been resembled over to this film when it is being placed in the opposite way around. So that is why it's called as a tire track appearance or a herringbone effect. Then in the projection errors, you have the crowns that are not shown, the partial images. Why is the reason of the partial images? It can be caused because of while your tube head is being placed not sufficiently positioned, or else it is positioned in such a way that your film is also being positioned improperly, where it is not coinciding with your tube head itself. So it can lead to a partial image. And then you have the overlapping of the teeth, that can be caused because of the improper horizontal angulation. As you know, the horizontal angulation, you should pass across the contacts in such a way that is perpendicular to the contacts of the tooth. So once that is not being followed, there is this kind of an overlapping of the tooth. And then you have shape distortion, artifacts on it, double images on the radiograph. Why the double images are being seen? It's because of the case where you're exposed to the film twice. That can also lead to double images, or the patient's position has been differing. So that is when you have this kind of an error. And then you have the blurred image, and then there's something called as cervical burnout, with the other name is known as the as an adumbration. So cervical burnout or adumbration, it's nothing other than apparent radiolucency that you see below the cemento enamel junction of the root. Almost in the contact areas itself, you will see this kind of a variation, because the root formation that you see in certain posterior tooth is that it is found to be concave. So it is more of an optical illusion kind of uh, a variant that you see, an error that you see. So this is can be asked as a short note or a short essay itself, that is adumbration, or the other name is cervical burnout. Next you have is the exposure and the processing errors, and that you have all this exposure errors. What is that? Low density film, high density film, the high contrast and the low contrast, fog, streaks, blisters, frilling. You have white spots and the black spots, clear film and the black film. All those things you can. It has been explained well in Freni Karjodkar. What are the cause and how to correct it? So have a read about it. And in the miscellaneous technique errors, you have the phalangioma. Phalangioma is nothing other than the patient's finger is being placed between the X-ray that is being exposed and to the film. It is between these two areas, your fillers and your fingers being placed. That is when you notice this kind of a error, that is phalangioma. And what next is the automatic processing errors. In that, again, there is a decrease in the film density, increase in the film density, there's streaking, fogging, peeling of the emulsion, there's sometimes the pressure marks that are seen. Also there may be a white cloudy appearance that are observed, scratches on the X-ray film itself surface. All these you can read it about from Freni Karjodkar itself under the chapter of faulty radiographs. So the next chapter is about X-ray films and the accessories. In that you can read from the textbook White and Farrow itself, wherein film imaging chapter. In that you have the composition of the X-ray film, which consists of the base, the adhesive, and then the emulsion. The base, it is formed of the polyester polyethylene terephthalate. It helps to support the emulsion itself, and also it provides the degree of flexibility to easy handling of the film. And emulsion, it comprises of the silver halide grains and the vehicle itself. So the silver halide crystals that are found is mainly composed of the crystals of silver bromide. And then the vehicle here, what happens is the silver halide crystals have been, or the grains have been suspended into this vehicle, and it is found to be applied in both the sides of the supporting base. So this diagram also can be seen, the X-ray film under the chapter of film imaging in white and farrow. Even you can refer in Freni Karjotkar also, they have mentioned it about the composition of the X-ray film. What are the components in it, and also what are the functions? That is what you should mention under this question. Next is about the X-ray films that have been used in the dental radiology. So we have intraoral films, that is the periapical films, wherein you have size 0, size 1, size 2, and the size 0 that is mainly meant for pedo or the children itself. So the size is around 22 to 35 mm, 22 into 25 35 mm, and whereas in the size 1, that is it is found to be used normally for the anterior teeth. So in that you have the size about 24 mm to 45 mm, and then you have size 2, that is the adults film, wherein the standard ones that we use is the 30.5 into 40.5 mm in size. And then the next you have the bite wings, wherein for smaller size for the children you prefer the size 0, and bite wing films you use for the adults is a size 2 itself. And then you have, there are also size 3 for the longer ones that are available. You have for the occlusional films, that is size 4, which is found to be 3 times larger than that of the size 2, and that can be used for the maxilla as well as the mandible. So, and then you have the extraoral films, that is around 8 into 10 inches in size, and all the extraoral films are being utilized for the extraoral radiography. Next is about the filters in dental radiology, which I have already explained in the previous session. What are the filters that have been used? Here we use the aluminium filters, which is found to be 0.1 mm in thickness, and we have the three types, that's the inherent filters, added filters, and the total filtration. Inherent, as I said earlier, it is the insulating oil as well as the vacuum, which is found within the glass tube itself head. And then you have the added filters, that is the aluminium filters have been added on with a thickness of 0.1 mm thickness, and the total filter is nothing other than the combination of both the inherent as well as the added filters. So the main mechanism of filters is nothing other than to remove all the low energy photons which can have a low penetrating potential, so it can compromise the image quality. So that is why it has been utilized, the filters. Then we have the intensifying screens that can be asked as short notes. So intensifying screens most commonly it's used for the purpose of extraoral radiographs itself. The function of the intensifying screens is that it creates an image receptor system in which it is found to be 10 to 60 times more sensitive to X-rays than it is to the film alone. So what it occurs is that it helps to reduce the dose of X-ray radiation for the patient. So these intensifying screens have been used for the extraoral radiography, as I've earlier mentioned, and the composition of this, it is again given in the textbook by White and Farrow, wherein the diagram has also been given how the intensifying screen has been composed of. That is, it contains the base, the reflecting layer, phosphor layer, and the protective coating. So the base is comprising of your polyethylene terephthalate, and then the reflective layer where it contains the titanium dioxide, and the base normally it helps to mechanically support the other layers, and it is also having a reflective property wherein it reflects the light emitted from the phosphor layer back towards the X-ray film. And also this reflective base, it has the potential to increase the light exposing the film and also results in some kind of a image unsharpness. So what happens is that because of the divergence of the light rays reflected back to the film, it tries to bring out this quality. And the phosphor layer, it's composed of the gadolinium oxysulfide terbium or activated, or the yttrium tantalate, and also niobium activated ones, wherein it tries to reflect those light of green or the blue wavelength lights have been reflected upon. So these phosphor crystals have the mechanism of fluorescence, wherein it can be increased by addition of certain small amounts of elements such as that of niobium, terbium, thallium also. So these have been the rare earth screens that have been used to convert the absorbed X-ray photons into a low energy, that is 4000 low energy levels of visible light is being produced. It helps to convert the X-ray photons to light photons. Grids, these are found to be used in the extraoral radiography, wherein it helps to improve the image quality by reducing the scattered radiation, and it helps to improve the quality of the image also. So it reduces the repeated chance of exposure. That is why grids are being utilized in extraoral radiography. So this is a diagram for that, grids. So the composition of the grids is found to be alternating strips of lead and plastic, wherein lead is found to be radio opaque and the plastic, as you know, it's radiolucent. And there are different types of grids, that is linear focused, pseudo focused, crossed, as well as the moving grids. Collimators, as I've already explained in the previous session, what are the collimators? Collimators are nothing other than a metallic barrier with a central aperture where it helps to restrict or reshape the size of the X-ray beam. So it reduces the patient exposure and unwanted tissue irradiation has been avoided in this. So it's kind of it helps to protect the patient from unwanted exposures. And you have the other types, that is you have two types, that is tubular, rectangular, even diaphragm kind of types are there in collimators, and rectangular collimators are more preferable. Next chapter is about processing. The question can be asked in processing is, what is latent image? And then describe the process of formation of latent image, describe in detail the steps involved in manual processing of radiographs, and then add a note about the processing errors. So the processing errors part we have already mentioned. Now we just have to talk about what is a latent image. So the definition of latent image has been given again in Frenny Karjotkar itself, wherein it is found to be a radiographic film when it has been exposed to the information carrying beam of X-ray photons exiting an object. The photosensitive silver halide crystals in a film emulsion interacts with these photons and are chemically changed, and these chemical altered crystals are said to constitute the latent image of the film. So once the question of the second sub question is the describe the process of the formation of latent image, you can start off with a diagram like this that has been given in white and Ferro again. So once how the latent image formation occurs is such a way that we have a crystal lattice, that is the silver bromide crystal lattice in the X-ray film that is placed in the emulsion of the X-ray film, and you have the silver as well as the bromide ions that are found to be forming this crystal lattice. And within this free interstitial silver ions, there are some traces of chemicals such as that of sulfur ions have been used so as to form a sensitive sites that you can see here. So there is a sensitivity site over here. What happens now is that X-ray photons one has been exposed. It tries to interact with the bromide crystal, wherein it recoils an electron, wherein it has a sufficient energy to move about in the crystal lattice. And then what happens? These electrons are being attracted towards the sensitivity site. And what happens over there? It tries to impart a negative charge to this region, as you can see in this diagram. And what happens over here? This silver ions, that is silver has a positively charged ion, it gets attracted towards a negative charge that is seen around the sensitivity site. So then what happens here is that this tries to move towards the sensitivity site and tries to form a silver atom, and this silver atom once it is formed, this forms the latent image formation. And when this silver ion reaches this sensitivity site, what happens is it acquires this electron and forms a neutral silver atoms. Then this collection of the latent image sites over the entire film constitutes a latent image. And once the developer has been exposed to this for processing, what happens over here is that it causes the neutral silver atoms at the latent image sites to initiate the conversion of the silver ions in the crystal to form a metallic silver. And then in the developer itself, the bromine itself tries to dissolve within the developer. The next sub question is about the describe in detail the steps involved in manual processing of the radiographs. You can refer again from White and Farrow textbook itself. There are around 9 steps that they have mentioned about how the manual processing of the radiographs have been taken. And if the question has been asked what are the different types of manual processing of radiographs, you can again read from Freddy Karjotkar, where they have mentioned there's a time temperature method, there is visual method, there is rapid chemical processing methods. All those can be mentioned under the chapter under this topic of the different types of manual processing techniques. And manual processing procedures, as I've said, you can read from White and Farrow textbook under the chapter film imaging itself. There are around 9 steps that they mentioned. You can read about it, how the manual processing is done. That is, first is replenishing the solution, then stirring the solutions, then it goes by mounting the films on the hangers, followed by checking for the timer and the temperature if you're going for the time temperature method. And then you go for developing by setting the timer mechanism, and then you rinse it in the water, wherein the water that is being placed in the water bath, you have to place it for around 30 seconds, and then you go for fixing the solution, and then in the fixing solution you have to place it around for 2 to 4 minutes. After that you wash it in the running tap water itself, and then for at least for 10 minutes there has been washed in such a way that it tries to remove all the residual processing solution, and then it's left to dry. So these steps you can read it through in the textbook of White and Farrow. And the next question in this that has been asked is the processing errors, which I've already mentioned in the previous slide. Next question that has been asked in the short note is automatic film processing. Automatic film processing is nothing other than automatic dunking models, which helps to produce a washed film that can still be dried up. So you don't need to manually do the processing in this. You just there's this kind of a there's this automatic film processor wherein you have a film entry. We just have to place a film within it, and then it tries to go from one solution to the next, that is from developing solution to the fixing solution. Then it goes for the water wash, and with the help of the rollers that are being placed, that helps to move the film from one solution over to the other. The advantages of this automatic film processing is that the processing is found to be less than 4 to 7 minutes, unlike your manual processing, and there's a uniformity for processing this in each solution, and there is also no wet films that has to be handled. Density and contrast is found to be consistent, and there is less flow space required for the automatic film processing. The disadvantage is that it is found to be a high cost of equipment and maintenance. The quality is not as high as manually developed radiographs. It can also have a tendency of more grains that can be found in the final image. To know the mechanism of the processing of automatic film processing, you can go through this chapter in White and Farrow itself, where they have explained each how the transport system of this developing or the fixing of the solutions are occurring in each solution. How is the film being processed? That all has been mentioned under this mechanism of automatic film processing. In function of this, rollers are found to be their motion helps to keep the solutions agitated, which contributes to the uniformity of the processing. And then the developer, fixer, and the water tanks, the rollers press this film emulsion, forcing some solution out of the emulsion. So the emulsions rapidly fill again with solution, thus promoting the solution exchange itself. So finally, the top rollers at the crossover point between the developer as well as the fixer removes the developing solution itself, minimizing the carryover the developing into the fixer tank. So that is why we avoid the water rinse part in this when compared to that of the manual method. In the manual method, there's a developing solution, then the water rinse and the fixing solution. This water rinse property is being taken up by the rollers itself. that are found in the automatic film processing. So that is why in between the developing solution and the fixing solution, there is no water process in this. So that is the difference between the manual processing from that of the automatic film processing. Then the next question that can be asked is the film processing. You can mention about the manual processing, then you have the automatic processing technique, and then the daylight processings. Then the next question that can be asked for short notes is the penny coin test. So the penny coin test is nothing other than to test the safe light condition in the dark room. So what we do is that such a way that onto the film itself, you place it in the dark room, the film with the coin over it, which can be placed for a few minutes, and then later in the darkroom setup itself, we try to process that film. Once you see a coin that is processed in the film itself, on the film image, then it indicates that there is no optimum safe lighting in that darkroom. So that is how it tries to assess the safe light condition in the darkroom setup. Next is a question that can be as a developing solution, that can be asked as a composition of it. You can speak about like how I already earlier mentioned, the components, the ingredients in it, and then the functions of each. Even sometimes fixing solution can also be asked similarly. So you can go about through the same way. Next chapter is about the intraoral radiographic techniques. So the short essays that can be asked is the object localization techniques. So under the object localization techniques, you have the buccal object rule, that is the tube shift or the Clark's technique, which can also be asked as a short note itself, which has been, I have already mentioned here with the diagram of what is tube shift technique or the Clark's technique. You can see here the tube shift technique, that is it follows a slob rule. Slob nothing other than same side lingual, opposite side buccal. So you can see here, once there are two objects, that's a foreign objects are being placed either side of the tooth, that is the lingual and the buccal. Once the X-ray beam has been entered through this, and then it hits the film, you will see here it is coinciding, the buccal as well as the lingual object, foreign object, is coinciding in the same position. Once you try to move this tube head more distally, what happens over here is that the lingual is found to be positioned onto the same side as that of the distally it has been placed. That is, you can compare to the previous image. Whereas in the buccal, the object is found to be placed in the opposite side. When you compare it to the position of the tube head, you are saying that from the opposite there is found to be buccal. If it is found to the lingually object, the foreign object that is being placed, it comes towards the same side as that of the where the tube has been shifted. So that is why it's called as a tube shift technique or the Clark's rule technique as such. Next is about the right angle technique. In this, the right angle technique, what happens over here is that you take two projections that are placed at right angles to each other to localize that object in the maxilla or the mandible. So one radiograph that you take is the periapical radiograph, just to show the position of the object supro-inferiorly and antero-posteriorly. Next you take is the occlusional radiograph, wherein it shows the objects buccolingual and the antero-posterior relationship. So then you compare these two, that is a periapical radiograph from that of the occlusional radiograph, so as to localize the objects in a three-dimensional way. That is what is about the right angle technique. Then you have a stereoscopy, which helps to determine the small intracranial calcification and foreign bodies in the dense or thick sections. So stereoscopic imaging, it helps to expose the two films, one for each eye, so as to deliver twice the amount of radiation to the patient. So between the exposure, patient is maintained in position, film is changed, and the tube is being shifted from right eye to the left eye position. So after processing, the film that are viewed with a stereoscope is used with the either the mirrors or the prisms, so as to coordinate the accommodation and convergence of the viewer's eye, so that the brain can fuse the two images together. So then you can assess the, now in cases of mandible, you can assess the mandibular canal to that of the root of the unerupted mandibular third molars. Even in the cases of any assessment of bone shape, when placement of dental implant can be considered under this technique. Next, you have the occlusal radiograph techniques and the indications. The indications for occlusal radiographs are to locate any retained roots of the extracted teeth, to locate any calculi or salivary stones in your mandibular sections, mandibular occlusal radiographs. Then you have to locate the foreign bodies and also to locate any supernumerary or unerupted or impacted tooth, to evaluate the cyst extension as well as the tuber in the maxillary and the mandibular occlusal radiographs. Techniques in the maxilla, you have three techniques, and the mandible you have three techniques. That has beautifully been described in Freni Karjotkar itself, and also even in White and Farrow under the chapter Intraoral Projections itself. They have a diagram as to how the projection has been done, and you can go through that. And along that, when the question is being asked for any describing the technique, you have to start off always in such a way that you speak about the image field, then how the X-ray film has been placed, and then the projection of the central ray and the point of entry. So you can go through the chapter in Intraoral Projections in White and Farrow itself. They have explained it well. All the occlusal radiograph technique, you have three types in the maxillary and three types in the mandible. Anterior maxillary, you have the topographic maxillary, then the lateral maxillary. The mandible, the similar one, it's the anterior, topographic, and the lateral. So just go about it and may always answer in the 4 points, that is image field, receptor placement, then the projection of central ray, and the point of re-entry of the central ray. Then next question that can be asked is intraoral radiographic technique. Once this question has been asked, you can formulate periapical radiography, bite-wing radiography, and the occlusal radiography. Periapical radiography, you have two types of techniques. There's a paralleling technique and the bisecting angle technique. Please draw the diagram along with that, how the paralleling technique is, how the bisecting angle technique is. Most commonly they ask the bisecting angle technique, and also you must know the other name for bisecting angle technique is short cone technique. Paralleling technique is other name is the long cone technique. Then you have the bite-wing radiography and occlusal radiography, which I have explained in the previous slide. As I said, bisecting angle technique, the other name is called as a short cone technique. Once this question has been asked, you should draw the diagram like this, and along with that you should speak about what rule does it follow. It follows this Anki's rule of isometry. So in the rule of isometry, what it means is that you have two triangles that are being formed. Okay, so the two triangles, the one is the long axis of the tooth and one is the X-ray film that is being composed over here. You have the perpendicular bisector to this. So you can see here this central ray of beam that passes across here, it passes in such a way that it is perpendicular to this perpendicular bisector. And what happens over here is that you can see here, once this perpendicular bisector bisects this triangle or the angle, it bisects it in two equal angles. So you have a two equal angles as well as a common side. That is what this rule of isometry is supposed to be. And in this, once they ask you question, again as I've said, you have to speak about how the film is being stabilized. That is, you stabilize it with the help of the snap array. Position the patient in such a way that once you're taking a maxillary radiograph, you try to place the occlusion plate is found to be parallel towards to that of the floor. And the vertical angulation, it depends on each of the which tooth is being taken or tooth of interest. It is highly based on that the vertical angulation. And then horizontal angulation is nothing other than the central ray that is directed through the contacts of the or the proximal contacts of between the tooth. So it is found to be 0 degrees. Again, the question of occlusal radiographs when asked, as I've already mentioned, what are the occlusal radiographs, what are the indications you have to mention, techniques each you have to mention based on the 4 categories, that is the image field, the receptor placement, then the projection of central ray as well as the point of entry. So this is a classification of the maxillary, the mandibular. You have the anterior, you have the topographic, and then you have the lateral. Bite-wing radiographs, when asked, you can say that it is used to detect the interproximal caries. So the indications are to detect the interproximal caries, to check the alveolar crest levels between the two teeth, that is the periodontal conditions are being detected so and so, and also to mention the change in the bone height based on the alveolar crest levels, and if any calculus is found in the interproximal areas. And the patient position is such a way that the maxillary arch is found to be parallel to that of the floor, and the mid-sagittal plane is found to be perpendicular to that of the floor. And you can see here the bite wing is being placed such a way with the bite tab, which is where the patient is asked to bite the bite tab over here, and the X-ray beam is directed in such a way that the vertical angulation for the molars exposure, it is found to be plus 10 degrees, and for the premolars it's found to be plus 5 degrees of angulation, and the horizontal angulation is such a way that it is directed through the contacts of the teeth. So again, the question has been asked about indications of bite-wing radiographs, which I've already explained. Next chapter is about the extraoral radiographs and the other specialized imaging techniques. So the short notes can be asked into this chapter is the subendo vortex and the jug handle view. Once the question has been asked about extraoral radiographic techniques, you should follow these headings. It's a film placement, the position of the patient, the central ray point of entry, and the exposure parameters. So the film placement is such a way that the cassette is being placed perpendicular to the floor, and it is found to be log axis of the cassette is found to be placed vertically. And the patient position is such a way in subendo vortex is that the vertex of the head portion is supposed to touch the cassette, and the mid-sagittal plane is found to be perpendicular to that of the plane of the film. And the central ray is directed in such a way that it is perpendicular to the film and through the mid-sagittal plane. So as you can see here, almost around a vertical angulation of minus 5 degrees is being given. And next is the modification of subendo vortex view. There is a jug handle view. And sorry, I have not mentioned over here the indications of subendo vortex view is such that helps to check for the fractures or any tumors of the zygomatic arches. Also to check of any skull base tumors also you can see in the cases of subendo vortex. Whereas a jug handle, as the name suggests, jug handle, it is found to indicated for the view of the zygomatic arches. As you know, the when it is viewed, it is found to be almost similar to that of the how you have a handle to the jug, and that's why it's called as a jug handle. The zygomatic arch represents as a jug handle itself. So in this, the only difference is that it's the technique and everything, the patient position is all the same. Only the exposure parameters are different from that of the subendo vortex. In jug handle, at least 50 to 60 kVp of exposure, as well as the milliamperage is around to 5 to 9 milliamperage of current is being tube current is being given, and the exposure time is found to be less than around 50 seconds. So that is why the difference between the subendo vortex from that of jug handle, the exposure parameter wise is the difference only between the either of the two. And you can view in this the zygomatic arches. If there is any fractures to the zygomatic arches, that you can be indicated for jug handle view. Next is the transpharyngeal projection of the temporomandibular joint. In this, again, the film is placed in such a way that the cassette is found to be placed against the patient's ear, where it has been centered half-inch anterior to the external auditory meatus, and then it is placed also over the TMJ of interest parallel to that of the sagittal plane. And the patient position is such a way that the sagittal plane is vertical and parallel to the film. And you ask the patient to open their mouth wide. The central ray has been directed at an angle of minus 5 to minus 10 degrees posteriorly. So the central ray is oriented in such a way that it hits against the mandibular notch or the sigmoid notch of the opposite side below the base of the skull. Next question that can be asked is the paranasal sinus views. So again, you can, all these extraoral radiographic techniques you can read from the textbook of Freddy Karjotkar itself, where they mentioned it properly along with the following headings, as I've already mentioned. What are the indications for it, what are the patient's position, the how the film is being placed, and also how the central ray is being directed, and then the next is the exposure parameters to be given for each view. So might as well follow from that textbook as if in the paranasal sinus views, again it is used to study the relationship of all the paranasal sinuses. You have the post PA projection, wherein you have the other name is the Granger's method, and then you have the Caldwell's modified method of the posterior anterior projection that has been given in the textbook itself. You can read about it from the textbook of Freddy Karjotkar itself. Next question that can be asked is Cylography. This can be asked as a long essay itself. So you can read again from the textbook of Freddy Karjotkar itself, where she has mentioned in the salivary gland tumors chapter or salivary gland diseases chapter itself, she has mentioned beautifully what cylographic technique is, and you can draw the relevant diagrams related to that. Cylography is nothing other than a radiographic procedure that is used to as an diagnostic agent to monitor salivary gland diseases, and it is helps to examine the ductal as well as the acinar system of the major salivary glands. That is your that is your submandibular salivary gland as well as your parotid salivary glands. The indications for cylography is that it detects the calculus. It helps to detect the extension of the destructed glands secondary to the obstructed calculi or any foreign bodies in placed. It also helps to detect the fistulae of the strictures, and also it helps to demonstrate the tumors as well as it diagnose the recurrent swellings. So in the procedure of cylography, you have three main steps, that is preliminary plain film evacuation, then you have the injection or the filling phase, and then you have the evacuation phase. So you have to explain in each phases what are the procedures that has been done. So in the preliminary, radiographs have been taken to detect the conditions without any requirement of any contrast. And then secondly, what we do is that we, in the filling phase, we try to ask the patient to consume the secretory stimulant for around 2 to 3 minutes, that is by asking them to suck a lemon wedge or so, and this helps to open the ducts for easy identification. Then next what we do is that in the ductal orifice itself we spray the topical anesthetic, and this the duct is then cylographic cannula has been inserted to this duct. Then the contrast has been introduced into this cannula itself, that is slowly it has been introduced in such a way that 0.76 to 1 ml of the contrast media has been given, that is the oil based or the water soluble iodinated has been given or injected, and then the images are taken immediately after the contrast has been completed. And once the images have been taken, the patient is asked again to suck the lemon wedge so as to evacuate the contrast in such a way that the cannula has been removed, and then we take the radiographs of the patient of the salivary gland itself almost 5 minutes after the removal of the cannula. So this is what the cylographic technique is all about. Thank you. We'll take up for the next session the other chapters.